section, thinking about what are some possible data linkages for the work that you're doing and what might be some of the challenges that you're facing with data linkages, or data quality. Are you in a position where you need to also be kind of building your own data set because the information is either not collected or it's collected very disparately across clinics or hospitals? So we'll open it up for questions and comments for our speakers.
I have a question for Katie. Are you aware of our IRB allowing any clinical projects using PHI to use cloud methods?
I'm not aware of any, but I think that would be a good question for the Center for Personalized Medicine, who probably has to utilize these type of resources. Do you know, Tom?
So Compass is in the cloud now. So the legal agreements were complicated as I understand them, but probably the campus is moving to being more understanding of that.
Can I just add one thing to that, sir? And I guess one thing I forgot to mention, the connection between suggesting R and Python is it's going to be really hard to find a cloud with SAS. So there are linkages. There's a program called Spark that actually sends your job out to these computers using Hadoop. And this is all linked back to R. I don't know of clouds with SAS. I'm sure they exist, but they're not cheap. So that's another advantage to learning those tools.
And we are going to have Sharon Devine come and give a talk at lunch she's from Colborn, and so she's going to talk about the ethical issues with linked data using big data, and also some of the obstacles and challenges related to data linkages and PHI and so forth. So good. So if you are wondering, want more information about that, sort of how to navigate Colborn applications, Sharon would be another great resource. And there'll be time, she'll give a short talk, and then it'll be open for discussion too. She will encourage you to ask questions specific to your projects. Other questions? So what about some of these issues related to data linkages? Are there projects that you're working on that there are opportunities for data linkage, and you're facing some challenges that maybe some of the speakers could address? Either linkages or data reduction and management strategies?
Bennett, how do you guys see the use of wearable devices collecting data and then integrating this data there?
Yeah, I mean, that's definitely going to happen and is desirable. And was on the figure from JAMA that I showed near the beginning of my talk, be it both, I think, as an exposure and also as an outcome for a variety of clinical or health questions. It poses the challenges, related to size and dynamicity of the data. But I think at the design level, I think this is where the field kind of needs some creativity in the sense of there's all this data out there, but people who have enough overlap of skill set such that they can both know the question and think of what might be brought to bear on it. That I think is going to be really exciting to watch.
I think, one of the challenges that I don't know we've addressed with that type of data is the PHI associated with some of that data. So you're talking about data that you're tracking people's movements and physical activity, and it poses a whole different question of if someone can be tracked to a specific location and time, how can you effectively use that large data set and still protect PHI? And I don't know that people have come up with really great answers just yet for how to do that, other than acknowledging to patient participants that could be a problem.
I'll just point out some resources on our campus where people are doing this. I don't remember the exact title. It's something like the Center for Innovation, M Health. Sheena Bowl runs that program, and they collect a lot of information like cell phone data. I'm also working with someone. There's a group downtown Denver called InWorks, and they have some courses are actually offering a degree program, and you can learn how to build apps and do things like that. But one of the people I've been talking to from a research point of view is someone who does work in Africa on transmission of disease and using sort of text messaging information. So, and this has been shown with influenza transmission, people texting their symptoms and correlating that with the probability that they have influenza, and so you have a geopositioning system. And so there's a bit of PHI there because you're literally tracking where people are going, but you're also tracking what they're saying. And so I think there's a real opportunity, and some of those things are happening on this campus, and I encourage you to reach out to some of these groups and talk to them. We have a person at Accords, Susan Moore, who does a lot with mHealth and works with Sheena. So
I think one example of something that there's a ton of innovation in this area that's coming down the pipes, and there's a lot of physical activity data that is one of the more logical, kind of easy ways to capture it. But one of the most interesting examples I've heard of in my field in a while is tracking physical activity. There's a group in Canada where they had people, they have their cell phones with them, and they looked at the gait mechanics that changed in patients who had osteoarthritis in their knees, and they used that as a trigger to identify when they should have surgery. So in other words, people would be carrying their phone in their pocket or somewhere on them, and they were able to develop with large data the ability to detect a deviation, a limp basically, that was a trigger for when people should have surgery.
Which is a prediction problem. I mean, the themes, run through all these talks today.
So Sal, I have a question for you. So could you tell us a little bit more about sort of the pragmatics of your data linkages that you were able to do it without PHI, and thinking about other sort of patient populations and how we might think about doing these types of linkages? Because I think that's something that's an area of interest for a lot of us probably, that we hadn't considered that we could do some of these linkages without PHI.
So there's a lot of interest internationally in what is being called privacy preserving record linkage, PPRL. And there are both technical solutions being developed, largely being brought in from computer science, and also sort of separation type solutions. And so this would be the you can link the data, but you have to come to our building, and our building isn't connected to the internet kind of solution. And then there's the if you happen to have enough information that you can link it without PHI, and that was the situation that we were in. I don't actually think that that's that common, but I do think it would be scenarios where whatever the process that you're studying, for me it was injury or disease severity, was on the higher end, and so that generated information content, and that information content made the linkage possible. The separation sort of, you have to go to a place, is also present in our community. For example, there's a new census data analysis center up in Boulder, and they are quite interested in having their data linked to other data sets, but you have to bring your data to them and link it there. And all you can leave with is kind of tables and figures. You can't leave with any data. But that is a door that wasn't open before. And actually the administrative director of the unit that oversees those centers attends that international linkage meeting, and we had a long conversation about this. So it would be great to see some Anschutz collaborations with them. I think that the technical solutions like bloom filters are probably going to get operationalized in the healthcare systems in countries around the world that are a little more integrated. They're already getting kind of beta tested in Canada and in Australia. And we hope to see more of that perhaps on a health system basis or on a state basis or perhaps a CoreNet basis sometime in the future.
So just a follow-up question to that. So you mentioned both the resources available in Boulder and then Michael Kahn's group that could potentially do data linkages or could do data linkages. So what would that look like, or what should people be thinking about in terms of in grant writing and think about what are the how would that look for in a grant proposal?
Yeah, I mean, if you're asking sort of, is it its own separate aim? In my experience, it has been. At this point, because the service is not online yet, I do think it would be a formal collaboration with Tone or one of us, and so it would probably require kind of sitting down and examining the problem to see what sort of how much time and effort would be required to do the linkage. In the future, there's hope that there would be more of a prototype service that could be more easily integrated as a block into a grant with more fixed pricing if the project met certain criteria.
Is it helpful? I don't know. I know Compass has come about fairly recently. Does anyone have information more specifically, like in terms of, I mean, I guess a collaboration approach is also kind of what's being encouraged with Compass, or more details on how to access that service?
I'm sorry.
Oh,
Yeah,
sorry.
yeah.
I won't get the acronym exactly right, but it's the Anschutz data lake, basically. So it's integrated data that is linked at the patient level between University Hospital, Children's Hospital, UPI, so the physician provider payer organization, and the School of Medicine, so the information about the providers. And so it is funded by those four organizations to both achieve kind of the missions of those organizations, but will also be made available for research and is available for research in kind of early beta phase.
I'm just going to add that if you don't have the funding to pay for people who are really experienced in this, learning SQL, you can implement that in SAS or Python. SQL code is the same across different programs. And once you learn that language, you can do some of this record linkage yourself. It's maybe not as high quality, but I think that just to know that if you have some data sets that you want to link and you don't have a lot of money to pay someone else to do it, it's not too hard to learn SQL and try it out yourself.
Other questions? Surely you guys have questions about projects that you're working on.
Should have had coffee in the meeting. Yeah.
My question is for you. I'm just interested in how do you think you should do that about nature? Like what kinds of beginners of that?
I have longer talks about the linkage. I'm sorry I didn't include those slides, but along the lines of that the kids have high injury severity, and so things happen to them, and that generates codes in the database, and it generates codes in both databases of the same form. And so we had sort of analysis data sets for the two databases that where the match variables are about 50 of them, and it gets into the nitty-gritty of linkage again, but 50 variables with a lot of collinearity, and then a relatively small number of variables that we could block on led to some computational challenges. But in the end, we were able to make it work for that high severity group. at a relatively small number of hospitals. So again, I don't think it would work for every problem, but if your problem has some of those same features, it might.
So some of those 50 would have been like diagnosis codes.
A lot of, a lot of procedure codes, and then a lot of kind of hospital event information, length of stay, and that sort of thing. When in the hospital stay certain things happened. Yeah, hold on.
Where did your data set split when you were doing this research? Like, did you break both of the complete data sets into your own system and then link them, or did you extract the patients that you could link and then bring them to your own?
So we couldn't know ahead of time who was going to link. So we had file sizes in sort of between 100 and 200,000 for both ahead of time. So I started this work at my previous institution, but both there and here, we had a linkage server, and so brought the data to that linkage server in as small a form as it could be to kind of go into the linkage software. And then there was definitely some iteration, testing different block variables, different match pass characteristics to increase the accuracy. And then we validated it using data from the two centers where I had identifiers, and we're able to kind of train the linkage on the identified data from those two centers. Does that answer your question? So yeah, it's computationally intensive. It took a reasonable sized server a couple of days at times when we got to the final model. Probably could have made that shorter now, but at the time, that's what we had.
Another hand back there.
Yeah, I'm feeling, particularly with cancer data, but I think this might apply to others. I get a lot of databases that will have different types of information, but not on the same people. And I'm wondering if you have any experience or seen any projects that attempt to combine databases that are on different subjects on possibly common profiles and try to beef up the data in a more public way.
I want to make sure that I understand your question. So you think the same people are there, and they are, so different people, different data.
Different people, different data. So say, for instance, one database has stage and complication information on a certain type of disease, whereas another has long-term survival information. The possibility of combining as far as you can do similar patients in the database in an attempt to try to get both pieces of information. Like I said, you can't do it directly, they're not the same people. But I'm wondering if there's any possibility of a more fuzzy kind of match.
I could see it as a two-stage problem. You know, if you first sort of were able to develop and test something that could accurately group patients of a certain type, and then link groups and analyze the other sort of data types.
Have you heard of anything like that? Or like I said, we can talk about that.
Please go ahead.
I don't know if I've heard of someone doing that. Statistically, you could do, as Debashis described earlier, sort of an initial unsupervised learning problem. So to identify the groups of people and call those the same. So it's almost like you're creating a cluster between someone on the left side data set and the right side, and then relating that to the outcome information now that you've linked them in a cluster. That's a fun statistical way to do it. I have no idea if that's clinically legal and meaningful though.
I think you would need some data to train on if you're gonna.
Yeah.
Excuse me.
Consider trying it, yet I'm just wondering, like I said, if anybody's tried it.
Yeah, I mean, I think I would look in the prediction literature. So there's a lot of phenotyping going on, and so if the first stage was phenotype development and validation, and then the second stage was linkage to the long-term outcome, was it data? Then I think you could probably solve it that way.
I have another question for Jen. So you talked about the protocols, and therapists are using the protocols that the goal is to have these standardized protocols, but then there is sort of this wiggle room, this flexibility for allowing for individual variations, and that's a sort of feedback loop. And that sounds like what Vashes was talking about this morning in terms of sort of dynamic aspect of data. And I'm curious if you can talk a little bit more about that. I mean, it certainly seems like for clinical practice that has a lot of clinical utility, but it also seems like it introduces much more complexity to your analysis. And so I'm wondering if you can talk a little bit about sort of that part of it, that sort of dynamic part, and kind of how you addressed it.
Yeah, you know, it's a fine balance to be struck, and we wrestle with it with a lot of our studies where we need to give clinicians, rehab is not you give someone a drug and you see if it works. There's a lot of subtleties in terms of how we approach rehab. So we give clinicians guidelines with milestones or frameworks in which they, thresholds that they have to meet or time frames over which they should be providing treatments. But at the end of the day, we also have to give them a little bit of discretion to emphasize different pieces. So it really is a balance between if we protocolize things too much, then we take away, a great example is if we have patients who have lower extremity weakness and we say you need to do these 4 exercises on every single patient, but you don't allow the therapist to choose to assess the patient and say this person has no hamstring weakness and therefore there's no benefit to doing a hamstring exercise. My time is better spent on other priorities, other exercises. So a lot of times in that type of example, we'll give therapists a choice of a certain set of exercises and they can choose a subset, or we'll give them a progression that they can choose from. But there are guidelines. And then in the case of Utah's Intermountain Health scenario, my understanding is that they had those milestone thresholds or milestones that the patients had to achieve. And the therapists were told they had to use NMES, which is neuromuscular electrical stimulation, at least 1 visit. They had to do some range of motion. They had to do some exercise intervention. But they weren't prescriptive in terms of the amount of time that they spent on specific interventions. So again, that interplay with deciding, someone really has a range of motion problem. They really need to be working on bending their knee and straightening their knee. And maybe a therapist spent more time working in that particular area, knowing that the milestone was dictated as whatever it was for that particular, for the patients. So kind of that balance between the two. And then my understanding in terms of the feedback is that they would bring back some elements of, and we've done this in some of our studies, of performance, like how often did you hit that mark in terms of being able to tell therapists you're either way above or way below what the other therapists are doing, or how much missing data. We use that as kind of a feedback loop. What's your hit rate in terms of what's the amount of missing data you have compared to your colleagues, and where are your patients performing relative to those of your colleagues in terms of functional outcomes. So those are some of the strategies we've used and other people have used to try and keep it live and continue to improve over time the quality of the data set.
And you adjust for those differences when you're looking at sort of the effect of the intervention on the outcome. Sort of thinking about those, those deviations are probably, they're not random.
Yeah, and sometimes we cannot adjust for them because it is really difficult to account for them in a very specific, so we feel like we give people enough of a framework that we can say, this was the protocol, therapists were given these choices. And sometimes we can say that, on average, 50% of therapists did this, chose these 2 exercises over these 4, whatever that type of approach. But to be honest, it's harder to adjust for because there's so many different gradations of some of those deviations. And so that's an ongoing challenge, I think, in terms of how we account for that. And I'm open to suggestions if people have suggestions for how to accommodate some of those deviations.
Does anyone have thoughts about that?
So I was thinking about this when Debauches was talking with the idea of recommendation-based things, and I think that's one thing that'd be cool to look at down the road with our. We think of it in rehab or in physical therapy, where all of our treatments are highly tailored to the individual. But I mean that's common across many, especially elective, like treatment approaches, and whether you could have sort of like someone with this profile. Well, if you're doing this, maybe this is another suggestion, and then you can kind of use historical data to kind of prompt you with different approaches, and then have either a propensity score system or something like that to be able to compare across those things at an observational data level. So we look at things like in protocol form, and we want to study them in a controlled fashion, but then when you build that into a real world setting, can you also use observational data at that point to kind of guide your inference? So,
yeah, that's really interesting. I mean, I think it's not just unique to rehab. Right? I mean, it's unique. It's all of this healthcare in terms of this for decision making and individualized medicine and so forth. But it does introduce some biases, right? Because those differences they're not random. And so how would you? So that seems like a good strategy to think about what prompted the difference, and then sort of that might be one way to kind of adjust for it. To come up with a propensity score.
The way that we've started to approach this is just by trying to embed ourselves in clinical settings to collect the data and be a presence there, And so I might talk a little bit about that later, but just the idea that we need to start by trying to get the data that can inform those analyses later down the road.
So the whole sort of thinking about variation in clinical studies, in my own field, for example, we are maybe catching up to the 20th century, but not the 21st century yet. But we have a long legacy of negative clinical trials, and variation is really tough on hypothesis testing. And we had way too much both within and between center variation to know if we were answering these questions accurately. Actually, the approach has been really interesting, even at the enormous NIH grant level. Now we have very large observational cohort studies open that is collecting data on that variation and applying analytic techniques like propensity analyses to these prospectively collected very high quality observational data in order to both test several pre-specified hypotheses and generate a very large number of hypotheses to move forward, and hopefully to drive the development of protocols that people will actually follow and the next round of trials. So we'll see if that's successful. But I think the variation is fantastic for hypothesis generation and terrible for testing.
What are those? Do you know the specific data sets, like what populations they're focused on?
I'm sorry to give a lot of TBI examples, but that's what I know the best. But these are both adult and pediatric TBI around the world.
Can you see me on this stand?
Either way is fine.
John Walton, College of Nursing. One thing we haven't really discussed yet is that we have an emerging capability to link providers direct to patients. I think of two examples. I know Dr. Bennett, with your work, we went across the street with children. We can identify all of the nurses taking care of those children and ask questions like, well, does a young nurse have, do they have outcomes with higher ICD, something like that? Maybe they're not doing the right things, that they're not being surveilling as well. And for physical therapists, I was thinking about that trajectory over time. Does the physical therapist matter as far as how well that patient progresses? So I guess sort of in a general discussion, I mean, how much is that worthwhile to kind of pursue as far as that intimate link between the provider, again, in a broad sense, and the patients and the outcomes?
Yeah, I think that's a really important question, because clearly years of experience or training or just individual kind of provider skill sets are going to influence some of those outcomes, and it's a way to evaluate performance essentially. And as we see more pay for performance types of models for insurance reimbursement or payment, I think that's going to drive a lot more of the development of looking at some of those types of analyses. I do know a number of my colleagues who have started to use these in outpatient clinic settings, like types of monitoring therapist performance. It's more complicated, and that relates to the big data problem in a hospital setting where you have multiple people touching each patient. So that's where I think it could be a really interesting question, because how do you deal with the noise of, and still be able to answer, how effective is this nurse or this physician amidst all the different patient populations and all the different other providers that they're interfacing with on any given day. But
No, I agree. I mean, as Devasha said at the beginning, the data is getting higher dimensional in every arena. And so these are dimensions that we couldn't necessarily access before. And we don't know. And so I think it's really interesting, both from a health system perspective, but also from an optimization of patient outcome perspective, probably some others. So I think absolutely worthwhile to study, and we probably need to be using techniques like those Katie mentioned in order to do it efficiently.
Yeah, I don't know if I have anything to add particularly to this conversation, other than, hierarchy is always good to account for from a statistical standpoint, because a lot of times the variation you attribute to your fixed effect could be explained better by what we would call random effect, or some effect that is sort of representing unmeasured factors. So we might not know why one clinician is better than the other, and our intention was not to measure all the factors on the clinician, but to say anyone under this clinician's care is going to be correlated in some way. So I think the more we can account for these sort of hierarchical designs, is better.
I have sort of a follow-up question to that. It's less data related, but when you start talking about variability across institutions or performance of particular physical therapists, those can be sensitive topics and kind of a difficult discussion, and require, I think, good communication with identifying who the stakeholders are, and kind of good communication with stakeholders. And I'm wondering if you've had experience kind of with stakeholder teams, and how you sort of address this issue. And I know it's not as data related, but I think an important consideration when we're thinking about explaining this variability, like once we have the results from a hierarchical model, for example.
I'll just give a quick example of a project I'm working on with a cardiologist, and looking at access to heart transplant listings by state. It's a nationally available data set. They don't give you the clinic name for obvious reasons. Well, I guess maybe not obvious, but they don't, because they don't want you to report stats by clinic. Now, one data set will give it to you by state. So we utilize that data to say, were you in a early adopter or late adopter of the Affordable Care Act, and how did that affect access to heart transplant listings? And it was very interesting. But we had a journal reject it without reviewing it, because they didn't like us pointing out this fact. So it's very politically, linked. However, another journal ate it up right away. So I think you're going to run into these issues. Some people are more comfortable with it than others, in my experience.
it is a very sensitive topic, because when you start collecting these data on, in our case, our surgeon performance, like we can tell you what the outcomes are across, the Denver area, across multiple surgeons, but then there are other factors that haven't been accounted for, such as the types of patients that are seen at the University of Colorado Hospital tend to be more complex patients because of the academic medical center. And so, and compared to other hospital systems and institutions. So is that really a fair metric? And we've avoided that conversation. So we don't release that data, and we haven't broached that topic with our surgeons for obvious reasons. But something that I think could help inform healthcare and practice down the road, if we can figure out how to use it in ways that were not damaging and to people's reputations, but then help improve their practice patterns.
Yeah, it's an interesting challenge. I mean, I'm definitely a proponent of reproducibility and transparency and open source, but policymakers can adopt data-driven tools that you release perhaps before they're ready. We had an example just a couple of days ago. We had a D4 visiting professor, and it was some of her work at Dartmouth that actually went into the CMS attribution algorithm and how they attach patients to hospitals. And she had some really interesting things to say about how happy she was or not happy she was that CMS adopted it at the point in her research when they did. And so I think there is some kind of, hopefully it's stakeholder engagement. I'm not sure that that's the norm.
Can't help myself but go back to Patrick's question earlier, because as I let it sink in, I think that perhaps the way you're thinking about it is a little bit backwards, at least from a machine learning point of view. So if you have one data set that doesn't have your observed outcome and one data set that does, and it's got enough variables that you think you can link people on, the idea behind machine learning is that you can learn from a data set where you have your observed outcome from the covariates and get sort of a prediction or sensitivity or specificity in terms of classification or even regression for the probability of that outcome given the covariates. And the idea is to transport that model that you learn typically using lots of different algorithms and cross-validation and apply that to your data set where you don't have the observed outcome and sort of impute their outcome. So instead of trying to merge them by covariates, it's almost the same thing, but I would work more with the data set that's complete and try to fill in what you don't know in the incomplete data set from what you learned in the other one. An example is something we're doing right now, which is funded by D4, looking at identification of post-operative, post-discharge infections in patients. And the complication is that if patients have an infection after a surgery, after they've been discharged, it's not in their EPIC data, right? So we don't know really if they had an infection. And hospitals have to report the number of infections post-surgery. This is something they're required to report. So how do we find those or identify them after somebody's left the hospital? So the National Surgical Quality Improvement Program does a manual chart review by nurses on about 10 to 15% of surgeries to figure out if patients had an infection. So we're going to use that data set to try to develop an algorithm for learning from the data what classifies a person as having had an infection or not. And so can we take that model and apply it to the 85% of the rest of the people who we don't have the resources to do a manual chart review on and predict, or I don't like to use the word predict when we're not really trying to predict something, we're just trying to find something in the data that isn't readily available. So some of the things we're looking at are ICD-9 codes, procedural codes, pharmacy data. So we're having to link, APCD with NSQIP and EPIC data to get enough of these variables together that we think could pretty easily classify. And there's a precedent for it because surgical site infection is a type of infection that's been shown to be well classified using covariate data, using just a multivariable logistic regression. And people have achieved 97% sensitivity, 98% sensitivity. But then there's things like a UTI, pneumonia, and things that people have achieved about 47% sensitivity. And so we're trying to improve on that. And you could just find out after all this work that nothing really predicts it well. But that would be my approach if I were trying to identify or impute an outcome without it being observed. That had nothing to do with data management.
Something similar to that in SQIP with predicting events and then bringing it to another data set that has the events to generate performance measures. I think that's something similar to what you're talking about. What we had tried for this was to generate other predictors. Specifically, this deals with the NSYP data set, which has cancer patients with no stage. And we attempted to use another database to try to compute stage using the data in NSYP. Not with my success. But something similar to that. So thank you.
Other questions? Any other comments from the panel? All right, well, we do have some time. So lunch is at noon time, and lunch will be provided, and Sharon Devine from Colborn will be here, and she'll give a short talk and be available for questions. So we can use this time as a break, or network with colleagues to ask, if you want to ask our panelists any specific questions, and we'll reconvene at noon time. Thank you. So one of the things we follow up with NICU patients, and we don't really have a great way of following them, but I'm just wondering if some of what you're talking about could be done with either Medicaid, some kind of claims data, either the Medicaid or all care. If you do, if you use some of the diagnoses, like if you had a subpopulation that you were really interested in, like a trach vent population, or some subgroup that maybe you could follow, either you do kind of their NICU course, and then so I'm interested in sort of, do they access therapy outside of, once they leave the NICU, and kind of what does that look like, what are their therapy patterns versus their outcomes. And I'm just wondering if that might be something that's possible if you had, I don't know how much information I would need from both data sets to be able to link beyond.